Welcome again, my colleagues, uh, in part two of our session. Thank you, Doctora, so much. You did very well, and you take too much cases, and this is very good sign. As I told you before, try to conclude the case as early as possible because the examiner wanted to examine you from different aspects, and he have no time. He have no time. I think. It was this your first case. This was your first case. You did very well. But I have two remarks. You are slow. This case is a startup case, and all of us know this is ODF. Plus, you see multiple bilateral lytic lesion, mainly in the shaft of the small metacarpal and the shaft of phalanges. There are no soft tissue calcification. My differential diagnosis, Ollier disease. What will you and you should tell me one common mistake, you waiting for me to ask. Don't wait. You should tell me, and I will compare with the previous. I will ask the patient for any history of pain. Otherwise, if there are any increasing size, I will do MRI. Like this, the examiner know you are enclosing and you are understanding all the situation. Then I bring to you this, and you did very well. You tell all the items that I want. Then this is the MRI. The MRI also, this is the CT, sorry. This is the MRI. You did very well, but you forget one important thing to comment on. See the vessels here? See? This is very important. The tumor shifting and abutting the vessels. This is very important sign and important to be mentioned in the report for the surgeon. He may injury these vessels and make a fatal mistake for the patient. Overall, you did very well. In this case, I give you 7 by 8. Next case. This case, you told me there are sclerotic changes. No, this is non-acceptable term. This is a sclerotic lesion. There are big changes. I know this is sclerosis, but when you tell me this is a sclerotic lesion, you mean something dangerous, not just a sclerosis, because there are a Codman triangle and the soft tissue. So there are a big difference between both of them. Then you told me you will refer the patient to MDT without bone scan. You didn't mention without CT staging. And one important point, you should image all the limb, all the lower limb, to rule out multicentral osteosarcoma. This one of the most important buzzword or most important management any examiner wanted to listen from you. I think you must put osteosarcoma or aggressive tumor on top of your list, not osteomyelitis, because there are large soft tissue. What will you do next? I will first, I will image whole the limb. Second, I will do MRI. Third, staging CT, and then bone scan. And finally, I will transfer to special bone center for open surgical biopsy. This is no true cut biopsy. This should be surgical. Why? Because the track of the needle can spill malignant cell. So it must be a true surgical biopsy. Yes, after that, in this case, this is a classic rheumatoid, old age female. Okay, you delete sometimes. You told me at the first this Jacob arthritis. don't expect in FRCR exam I will any examiner will bring you Jacob last rights. They want some disaster. They want you to pick up and to save patient. Okay. And then you didn't ask me. I wanted to Zoom. I know here we didn't have Zoom option, but in exam you have. And asking for this question is very good for the examiner. Okay. Second, there are erosion here. There are very articular osteopenia, and you only mentioned the ulnar deviation and the boutonniere. And what about this? This this thumb has a very common deformity. Hacker thumb deformity. I will demarcate you because of this. There are impacted fracture, and really this is the main cause that I bring this. Distal radius, distal ulnar impacted fractures. Take care. I know this is in the beginning of our preparing acceptable, but take care to avoid it later. Even compare by the contralateral side. There are wide difference. At least tell me I want the other view to check what is this. There are a deformity. This is not looks like the contralateral side. I suspect deformity versus fracture. At least I will not demarcate you. Okay. Then this case. This case also is a classic, and you did very well. This is a bone infarction in old age. We should ask for the different histories, uh, lower femur and upper tibial serpiginous sclerosis, which denoting most probably bone infarction. And then you enumerate the different causes. I ask you to give you
Yasmin, give
higher
the
mark.
Laban to Harim.
Hello? Hello? Mute yourself, please, my candidate. My colleagues, please. What is the most common complication here? Sarcoma or osteomyelitis? How could you differentiate between infarction and vascular necrosis? Infarction is intramedullary, but osteonecrosis or a vascular necrosis is a subcortical necrosis. And both of them are due to cessation of blood vessel. Okay. I think there are one case, I don't know what is it. The case of aneurysmal bone cyst. The case of aneurysmal bone cyst, I will show you here, but you tell two buzzwords which you should know me. You first you bought fiber dysplasia, unicameral bone cyst in the top of your differential diagnosis, despite this very expansile lesion. Please, my colleagues, you should put some strategies for yourself. When you see very expansile lesion like this, and it looks like benign for you, put APC or aneurysmal bone cyst on top of your differential diagnosis. Second, you wait in the five cases, every case, you wait for me to ask you. You wait for me to ask you. Please don't wait the examiner to ask you. You should immediately give differential, give management. Don't give him any time. This is good sign when you are in the correct pathway. This is the MRI. You ask me to do CT. I think in this case, in all MSK cases, ask for MRI except one case. Except if you have a doubt or you have a differential diagnosis, this osteo. Otherwise, ask for MRI. This is MRI, fluid level, multiple fluid level expansile lesion. This fluid level because the aneurysmal bone cyst is a multiloculated blood-filled spaces of variable size separated by fibrous. And I'm waiting from you to tell me I wanted to see the post contrast to differentiate primary from secondary or benign versus malignant because we know that giant cell tumors and chondroblastoma and telangiectatic osteosarcoma can give in X-ray subpupil appearance and in MRI multiple fluid level due to cystic degeneration, but they show soft tissue component, enhanced soft tissue component in MRI. Overall, you did very well. All these notes, my colleagues, for you. Repetition will add to your experience, and I think you will pass if we are consistently study and preparing. Third candidate, please.
Yeah, Dr. Roshni is the third candidate.
Yes, sir, I am here.
Hello, Dr. Roshi.
Yes.
25 years old female patient with lower back pain for many years, followed by bilateral lower limb weakness.
Okay. Can I ask for the remote control or?
Okay, sure. I give to you. Time us, please, Dr. Amiga.
Yes,
Go
doctor.
on. Yes, go on.
Sorry?
Go on.
It's almost half an hour.
Hello, can I start?
Yeah, start.
Okay, I am provided with the MRI sagittal images, T2 weighted images of an lumbar spine. I am scrolling through the images. Here I can see that there are multiple blocked vertebrae are noted. There is a fusion of L5 and L4 vertebral body and L3 and L2 vertebral body is noted. And I'm scrolling through the images. The other vertebral body appears normal. Um, the it's just leaking.
Look at T1, please.
Okay, I'm going to
Leave
the.
them out. Leave them out. Look at
Okay.
T1.
Okay, I am provided with the sagittal T1 MRI images of the lumbosacral spine, where again this is showing the fusion of the vertebral body, and I can see that there is an abnormal signal intensity noted within the L2 and L3 vertebral body, and it is in a hyperintense signal. And the abnormal signals are also noted within the L3 and L4 vertebral body. And there is a reduced disk space between them, and this can suggest secondary to a discitis. I will look the spinal cord if there is any involvement of the spinal cord or there is any intraspinal extension of this.
This is
I would like to see
There
the post contrast images if available and star images.
are no post contrast. No
Okay,
post
so
contrast.
this so there is so there is an fusion of the vertebral body and there is a irregularity at the end plate disc space, and there is ankylosing. So I'm thinking of discitis. This
Which
can be
type of
due to
discitis? Which type?
as it is involving the two different level vertebral bodies. This can be due to pyogenic. This can be likely due to tuberculosis spondylitis. But I could not find any paraspinal collection or
How could you differentiate TB from biogenic spondylodiscitis?
sorry.
How could you differentiate tuberculous spondylodiscitis from biogenic spondylodiscitis?
Usually there is a paravertebral collection and there is a subligamentous extension.
What
There
else?
is a multifocal vertebral level involvement, and
What else?
gibbous deformity is also
Mm.
present in the tuberculosis, um,
What's your
so these
management?
I will
What's
inform
your
my
man?
finding to the referring physician, and the aspiration for cytology and culture would be recommended, and referral to the referral to the orthopedic MDT would be advised for further management.
Okay. Yes.
Okay, I have been provided
20
with a
years
front
old, 20 years old patient with chronic scoliosis.
20-year-old male patient with chronic.
Scoliosis.
Okay, I have been provided with a frontal radiograph of an chest and abdomen. Looking at the radiograph, I have noticed that there is a deformity noted within the vertebral body of the thoracic and lumbar region, and there is a significant scoliotic, scoliotic deformity with concavity towards the left side, and there is
How
also
could you
VG.
measure the scoliosis angle and what is the value?
It is measured usually by a Cope's angle.
What is the value? Tell me.
Uh, I don't remember the value.
Okay. Could you enumerate the different anomalies which you seen here?
There is a wedge-shaped deformity, and I think there are hemivertebral bodies are there as well.
Okay. Okay.
And apart from that, I couldn't find any spina bifida or
Okay. How many types of scoliosis you know?
there are it can be due to idiopathic cause,
Okay.
and
What
there
else?
are this can be due to a certain like a congenital condition like neurofibromatosis, or
Okay.
this can be occur due to some like renal calculi, which because of the pain there is a certain scoliosis.
Okay. What else?
Other would be due to certain pathology of the vertebral body and congenital anomaly of the vertebral body, and I think Klippel-Feil syndrome.
Okay, Dr. Roshi. 6 years old male patient complaining of lower back pain and the bilateral lower limb radicular pain.
I have been provided with a frontal radiograph of an skeletal major patient who is presented with a complaint of radiculopathy. And looking at the radiograph, I can see that the bilateral hip joint appears normal, bilateral sacroiliac joint appears normal. Um, there is a abnormal lucency noted within the region of the sacrum. Uh,
No lucency. No lucency. Hmm. What else?
Looking at the bones, the bone density appears normal.
Concentrate on the sacrum.
There is a lucent lobulated lesion noted within the sacrum. Uh,
No. No lucent lesion. What else?
the sacrum appears to be expanded slightly.
Okay.
So in my routine practice, I will go with the CT scan images to further characterize it.
This scan. You have the control, I think.
Okay.
Yeah. Hmm.
Uh,
You
Are
have
you
the
scrolling
control?
or I am scrolling?
No, no, scroll.
Okay. I could not scroll. Okay, I have
Scroll.
been provided with a sagittal MRI images of the spinal of the lower lumbosacral vertebral body. T1 weighted images. I can see there is a large hypointense mass noted at the region of the lower sacral vertebral body, and it is an expansile. It is extending within the pelvic region. I will in my routine practice I will look at the T2 images and post contrast images if available.
This is T2.
I have been provided with the axial T2 images, and where I can see that there is a larger T2 hyperintense mass noted, which is involving the sacrum and sacral foramina, and also extending within the pelvis. This can be due to
What's your differential diagnosis?
the one is this can be due to chordoma. The other is a
What else?
uh,
What else?
chondrosarcoma, but
What
usually this is
else?
on the like this is not the midline usually.
What else?
Other sacrocoaxial teratoma, but in this age group are least likely.
What else?
What else? These are the lucent. The Mets can be one possibility in this patient.
Do you know the origin of chordoma? The pathology origin?
Sorry.
The pathology origin. What is the pathology of chordoma? Do you know?
I think it's this is origin of notochordal origin.
What other places you? you could expect chordoma.
It is also occur within the skull in the clavus bone.
Excellent. 20 years old male patient post-trauma.
Okay, I have been provided with a frontal radiograph of a knee joint, right knee. Looking at the radiograph, I can see that there is a bony fragment noted on the lateral side of the lateral tibial condyle
What's
region.
your diagnosis?
This is on the lateral side, so the second fracture.
What will you do next?
I will inform my finding to the referring physician and refer this patient to orthopedician for further management.
Before referring, what will you do next in your department?
The orthogonal view.
बेटी बैठ के बात कर लो
No, this is orthogonal view. Please, my colleague, mute yourself. Please. What will you do next?
The MRI would be done in this patient.
Why? Why?
To see the ligamentous injury, anterior cruciate ligament injury, and the meniscal
What is
injury.
the association? What is the association of secant fracture and the
And
other injury? Mm.
there is a tear of the anterior cruciate ligament, also the medial meniscus and medial collateral ligament.
Okay. You can scroll. Hold on. I will scroll for you.
Okay.
This is the coronal.
I would like to see the sagittal images of this patient.
Look first here. Tell me here. What is the
Okay,
booking here?
I've been provided with the coronal star images of the knee joint where I can see that there are abnormal hyperintense signals seen within the medial condyle of the femur,
Yes.
and there is a significant joint effusion and edematous changes are also noted within it. There is I cannot appreciate the anterior cruciate ligament at its normal position. It is replaced by abnormal signal. So this is a confirm of anterior cruciate ligament tear, and I can see that there is a um I think a buckle. I would like to see the medial meniscus menisci.
It is fine. It is fine. Okay.
Yes, fine.
The
Okay, the
meniscus is
lateral
fine.
meniscus also appears normal.
Yeah.
So there
Look
is a
again.
buckling of
Look
posterior
again.
cruciate ligament.
Look again at this slide.
I think the anterior horn of the medial meniscus appears slightly truncated. If there is
Is this a median meniscus?
this is a lateral.
So
So there is a hyperintense signals are noted within the posterior horn of the lateral meniscus. So this is a meniscal tear.
to conclude your finding, Dr. Amiga, we have time.
So this is suggestive of post. And there is an evidence of second fracture. There is an evidence of anterior cruciate ligament injury. So these are suggest. And there is a joint effusion. So this is a suggestive of traumatic knee injury, and referral to the orthopedician would be required immediately for further management.
Okay, Dr. Amiga, we have time.
Yeah, we still have 2 minutes.
Okay, 16 years old male patient without trauma. Suddenly he has a severe knee pain, and this is MRI done for him.
There is no history of trauma.
No history of trauma.
Okay, I have been provided with the sagittal MRI images of the knee. Looking at the radiograph, I can see that the bones appears normal. There is no any abnormal intensity noted within the bones. The posterior cruciate ligament also appears normal. I could not see the
Okay,
I could not see the normal anterior cruciate ligament. So I would like to see the anterior cruciate
it's
ligament and
fine. It's fine. ACL is fine.
Okay, so I will look at the meniscus if there is any meniscal tear. On the stern image, I can see that there is a large joint. There is a large joint effusion, along with there is a significant edematous changes, or noted within the anterior as well as the posterior aspect of the knee. Um, uh, I'm looking at if there is a tear of the the quadriceps tendon.
Excellent. Continue.
So this is the fibers are appears like there is a gap between the attachment of the quadriceps muscle. So this is, I'm thinking of there is a tear of the quadriceps tendon, um, and there is a significant joint effusion and edema. So I will inform my
Will you
finding
the
to the
next?
referring physician and refer this patient to the orthopedician for further management.
What are the cause of rupture here despite absence of trauma?
Despite absence of trauma, this can
Could you tell
be
me some causes or some association?
like usually, I think there is a
This
this
old
is
age patient.
this can be due to old age of the patient and there is a weakness of the tendon and the muscles.
Thank you, Dr. Arash.
Time is
Thank
up.
you. You did very well. Finish. I think 15 minutes finish. You did very well. This case really was a little bit difficult because most of us are looking at the meniscus and the ACL, PCL. However, you picked up despite late, but better than nothing. This is a quadriceps rupture in a non-traumatic old patient. You should immediately tell the examiner, I will ask for any history of chronic diseases like diabetes mellitus, chronic renal failure, gout, or connective tissue disorder like systemic lupus erythematosus, rheumatoid arthritis. In addition, also corticosteroid long intake is a very common associated chronic etiology of spontaneous non-traumatic rupture of the quadriceps tendon. This case we smashed like this, and then we will transfer to which MDT orthopedic for surgical. Okay. I gave you 7/8 in this case. You did it very well. In in this case, you finish the case here in X-ray and you transfer the patient to the MDT to the orthopedic. Like this, you can make the examiner not pass you. Okay? Because I get that you don't know the very dangerous association with secant fracture. So I ask you about it. Secant fracture, which is a fracture of the anterolateral aspect of the lateral tibial plateau, is very commonly associated with ACL and meniscal injury. This sign, which bony chip lateral to lateral tibial plateau, called lateral capsular sign. Next step, I will do MRI. Why? Rule out associated ligamentous and meniscal injury. Here, you did very well. Non-visualization of ACL rupture. And then this is intact. Menisci should be black. If you see the menisci black, it is completely normal. This is the medial meniscus. Then look at the lateral meniscus. Here, there are abnormal signals here in the posterior horn, and also the body. The body looks like truncated. This is not the normal, and this is not the normal size. Looks like smaller. So there are injury of the body and the posterior horn. In addition, here there are injury here, not here. I think here in the lateral retinacular ligament, oh, there are some sprain here. Also here, and this is the site. You should start with the lateral side injury. You wanted to skip it, and I told you, no, tell me about this. There are complete rupture of the ligamentous complex here, completely. Okay, what is the difference between secant fracture and the posterolateral complex injury? In the secant fracture, most of the literature said that this is a rupture of the middle third of lateral capsular ligament and iliotibial band. While in the posterolateral ligamentous complex injury, it includes injury of arcuate ligament lateral collateral, and posterior surface of the lateral capsular ligament. Not important to يعني to memorize all of this, but at least you should know. You should know that the second fracture is at the lateral aspect of the lateral tibial plateau, while the acute sign or the injury of posterolateral ligamentous complex, the injury here at the head of the fibula. Case before, this case also you take too long time. My colleague, I repeat again, if you expect this is a normal bone, try to suspect either periosteal reaction or discrepancy in the bone density. Look here, you can't detect well the sacral foramen, and this is the key. Here, this is sacral foramen by way. This is not bowel. This is sacral foramen. Sacral foramen. Foramen. Here, nothing. There are no at least. So there are some abnormality here. Increased sclerosis. Tell me anything. Increased sclerosis, sclerotic lesion, and then describe. There are ill-defined cortex here. I suspect there are large mass here or a mass. It may be a mass. I think you told me there are something here at the beginning. As I think, but you don't know where is the origin. No, this is the lesion at all. Whole of this is the lesion, and the center is here, sacral lesion. What is your next step? MRI. Remember again, in all MSK, you should do MRI, except if you suspect osteoid osteoma. Then after we did MRI, the lesion is very obvious. Here you didn't comment either there are intraspinal extension or not, but anyway, you smashed the MRI well. My colleague, take care. On the flat bone, Ewing sarcoma, giant cell tumor, chondrosarcoma are very common to arise from flat bone. In addition to the common triple, lymphoma metastasis, plasmacytoma. Lymphoma metastasis, plasmacytoma. You can include this triangle, dangerous triangle, in any case. This is a case of scoliosis. Scoliosis measured by Cobb's angle. Cobb's angle should be more than 11. And I bring this case because all of us are weak in the anomaly of vertebrae, even me. I remember myself and you. Okay, this is a hemivertebra. This is, I think, a butterfly. Okay, I bring this case to enumerate different type of vertebral anomaly, and I think this also a partial vertebral block. Here also there are some block, and like this. Okay, this is the cause that I bring this case. Please, candidate, the next candidate, prepare yourself. This case was a startup case. You told me this is a blocked vertebrae. No, how could blocked vertebrae is very high signal. So I told you, look at T1. Then you stand up again and tell me, and you run away in the correct way of the TB spondylolisthesis. But I'm very sad because TB management, you didn't cover it well. Please, my colleague, TB management, you should almost you will get one case, either in Viva or either on long case. It's very important. First, I will isolate the patient. Second, I will inform the preventive medical authority. Third, I will transfer to the MDT, whatever here may be the spinal MDT or the ortho for measurement. What measurement? Surgical drainage. But there are no abscess. You told me here, you will aspirate. Aspirate what? there are no abscess. This patient need empirical antituberculous. Overall, you did very well. You are very confident. Just some mistakes which will improve, as I think, by practice. Next candidate, please. Welcome.
Yeah, Dr. Akira is next to go.
Let's start this candidate and then join the last Zoom link, please.
Okay, sir, I'm here. Should I start?
1 minute. Dr. Akila, our great doctor, 20 years old male patient complaining of hip pain. This is the first image for you. Go on.
Okay, sir. This is a scanogram of a 20-year male patient who presented with hip pain. I'm looking at the lumbar cervical spine and the pelvis and the abdominal head joint. I feel the left hip joint is abnormal looking. I suspect there are some loosened areas in the femoral head on the left side, and
Excellent.
also I suspect left femoral head, and there is some protrusion, protrusioacetabular on the left side as well. Yes, this is CT. Coronal view, I can see multiple loosened areas in the involving the left femoral head as well as the acetabulum, and
Yes.
the joint space is reduced.
What's your diagnosis?
Disease is crossing the joint and involving both the acetabulum and the femoral head. This represent a stage 4 area according to, I think, Patrick. It's
What's
stage
your
4.
differential?
The second is it could be inflammatory arthropathy leading to
Okay.
the rheumatoid arthritis.
Okay. What else?
If previously there was acute presentation, it could also involve septic arthritis leading to destruction of the bones.
What will you do next?